is a very interesting topic. It's one I didn't feel like I knew enough about, so I wanted to know more. And the only person I really knew that knew much about it. So if you go way back to like episode 2 on the podcast, I talked to Pete Dilla. And I actually talked probably twice as long before we started recording as we did after we started recording. And he was telling me all kinds of things, but he told me about TMJ and some of the stuff he did. And then I have some video recordings of Pete teaching that Josh Lawler sent me. And I watched his teachings. And what's amazing is his teachings are probably from the early 90s, and they're spot on. Like, they're everything right. So it's pretty amazing. It doesn't change that much.
That was episode 2 when you were talking to him?
Yeah, I talked to Pete Dilla.
I'll have to go back and listen to that.
Yeah, we talked a little about what he does now with Caracal Consulting.
Yeah, it's incredible, too, because we learned so much about cranial nerves. And honestly, I don't know if we know too well how to apply it, actually, to our patients. Like, we learn about them. We memorize all the mnemonics you could think of. And then actually come down to patient care. It's super important to utilize, but I don't think we get a great understanding of it when we get taught it.
We're taught.
Yeah, it's probably true. I've been in an email conversation with me, Kristen Fellows, Josh Lawler, Denny O'Hara, and David Geary, and we've been going over some cases and stuff. And Denny just gave us like a little primer in cord pressure, and it was all stuff I'd never heard. And so it was kind of crazy. So it's like, just keep writing, because he'll send you an email in between patients, and then a few hours later he'll send another email before he left off, and then at the end he'll be like, "Hold on, I got a patient." He's like, "Okay, I'm back." And so he just picks it up, and so you get this chain of emails. But man, they are brilliant.
Dr. O'Hara says things that I feel like a lot of people feel like when they're done talking, they said they've never heard it before. That's a common theme when talking about Dr. O'Hara.
But yeah, he was talking about cord pressure and whether the cord pressure is more central, and that determines whether it's going to be more sensory or more motor. He told Kristen, he said, "Do her hands swell early in the morning?" And she's like, "Why does that matter?" And he said, because if her hands swell, then the cord pressure is in the motor fibers, because the motor shows up in a physical presentation. But if it's in the sensory, it's just a sensory thing that they feel. And we were like, how come nobody ever told me that before? So it's things like that. And so he's like, look for the motor signs, like you'll get a physical change if it's motor cord pressure. We always just look for cord pressure. We didn't even talk about there being different types of cord pressure. So now I'm kind of like trying to pick his brain and understand this concept.
Yeah, and then he was even telling us that there could be cord pressure at the atlas, the CT junction, TL junction, right at L2 sometimes. Like all these things where we focus so much on the upper cervical cord pressure. But he was like, oh, yeah, if you just go down and you see after T6 it stays to the right the whole time, then there's a pretty good chance that there's cord pressure there. And we were like, well, that's
which is from extra posteriority. And if it goes that far posterior, it's going to drop inferior. So now you've got an inferior listing. So you got to make sure you get enough lift before you set it P to A, or you won't get it. But that's basically what's happening. And then it's pinching on the front side.
Yeah, there's so much to learn. And I mean, it's awesome that you say that too, because you've been practicing for 21 years, right?
Yeah.
Yeah. And I mean, you're still hearing things that you've never heard before. So it's...
I think one of the hardest things is when you're in practice and you've got all this stuff crammed inside your brain, but then you have a patient in front of you and you go, which stuff do I need and which stuff do I not need? And you can think of like this crazy scenario, but then if that person's right in front of you, you might totally blow it and do something else really stupid because you didn't recognize that. It reminds me of like my kids' things where they have like the pictures on this side, the pictures on this side, and you have to draw the line to connect them. Like, we're drawing lines all over the place because we don't recognize that this is that case. That's what you do here.
I know.
I think that's one of the hardest parts.
It's great, though. I mean, that just shows that you never stop learning, ever. Ever.
Yeah.
Hey, Doug, we got a pretty good group on here. We're ready to go ahead and get rolling when you are.
Okay. I have never used Google Meet, so how do I screen share on here?
If you go to the bottom and you see the second one from the right that says present now, should be like a rectangle with an arrow pointing up.
Huh. I don't have that.
Are you on a laptop?
Yeah.
It should be 2 buttons next to the leave call. So the red leave call button at the bottom.
Oh, okay.
So
I see it. I'll present it. Got it. I was on the wrong side. Okay.
And then your entire screen.
Yeah, I'll do my entire screen. I'll just blow up the PowerPoint.
Yeah, whenever you do that, we can see everything on your screen, so we'll be able to see it. And then we can zoom in on our end as well if we need to.
Okay. So I'll share that. And then there. Oops. Oh, that's fine. I'm not going to show that video anyway. Okay, can you see that?
Yes.
Okay. All right, then I will just, let me get rid of this hide button. Okay. And I'll just go through this. When I put this together, I knew in the extravaganza that there probably would be some students in there, but I knew that there would be doctors and doctors who had practiced for a while, and I knew one who had this frustration, which I had, and the frustration was TMJ was not like other joints. That certainly with the spine, if I have somebody with a spine and I can adjust 3 to 5 times, I know that even if they're not 100% better, they're going to be significantly better. Even with an extremity, if I can adjust it a few times, it's going to be a lot better. TMJ is one where you might adjust it and adjust it and adjust it and adjust it. And you're like, why is this patient not showing any improvement? And it gets very frustrating. Or you might try to adjust it and be like, I'm not even sure if I'm even adjusting this joint. I don't even know if anything's happening. And so it's a very, very frustrating joint. And it just kind of seemed like this challenge. So I kind of related TMJ just by doing some research. I found its connection with some upper cervical stuff, and I found its connection with some cranial nerves. But ultimately, what really got me going down this path, basically just going to walk you down the path that I took, and it all started with a case. So let me start there. This is James. James, I started seeing James when he was still in high school. So I've seen James for a long time. And James always just had, I think he had like an L5 problem, and sometimes he'd have something in his thoracics once in a while. And that's what I adjusted on James for the longest time. In fact, most of the time it was his L5 that bothered him. Well, James comes to me, and he's been referred to me, which was kind of weird. I'm like, he's already my patient. What do you mean he's referred to me? He's referred to me by the orthodontist. This particular orthodontist practiced right next door to my wife, and so I know this orthodontist well. In fact, on one occasion, he came next door, and he said, I'm looking for the doc. And my wife's like, I'm right here. He's like, no, not you, the other one. She's like, I'm so offended. He came looking for me, and he said, I got a girl sitting here with a TMJ problem. I need to make her a splint, but the problem is I can't get an impression because she can't open her mouth. Can you unlock it for me? So I walked over next door, and she's in her orthodontic chair, and I adjusted her jaw, and boom, it opened right up. And he's like, thanks, and he was able to do his thing. And the mom was just kind of like, who is this? I was wearing my Humphrey Pediatric Dentistry t-shirt. So she's like, who is this random dude that just walked over and opens jaws that are stuck? And so that kind of situation is kind of what I had with this guy. And so we referred back and forth a lot. And I picked his brain as often as I could. And so he sent me James, and I was like, okay, so what's the deal? And James tells me a story. He said I had bad teeth, didn't like my teeth. So I paid a dentist, turns out it's a general dentist, a whole bunch of money so that he could cap all my teeth and do this thing and make them look better. He said, ever since then, I've been basically unable to work totally responsive. I'll give you the list here in a second. So he shows me this x-ray of himself. And the teeth are usually a little bit angled, but in this case, he's got a bird beak. And so what you get is some really odd occlusion. And we'll talk about this a little bit later, but a lot of TMJ has to do with the timing of when the teeth collide, when they hit. And so, so he was having a major problem with that. It affected his TMJ and basically made him, he had to quit his job. And again, I'll show you the list of symptoms here in a second. And so this was his situation, and it was causing him a lot of trouble. So we've got many different causes of where TMJ can come from. So that's another thing that makes it complicated. Is a lot of times we say, well, it's this or it's that, and we have an idea of what's causing it. In this case, there's a lot of different things, from injury to the teeth or jaw. This is probably the most common one. It's called open mouth trauma. And in fact, probably the leading cause of open mouth trauma is dentistry, because in most cases, they're going to inject you and make you numb. Typically, they use Septicane or lidocaine. Those are the two most common ones. One is a little bit deeper sedation. Once they've done that, obviously you've lost your proprioception and you don't feel anything in your sensation. So now they're pushing against you and you don't really have the ability to push back. So and then your mouth is open for a long period of time while they're doing surgery. So that's a common cause of open mouth trauma. And I only bring that one up because it's not to say, well, whatever you do, don't go to the dentist. No, you need to go to the dentist. You need to have healthy teeth, but it is recognized that this is a common cause of open mouth trauma. So we need to do what we can to prevent it. But then when it happens, we also need to know how to fix it. Misalignment of the teeth or jaw, James. Teeth grinding or clenching, bruxism is the technical term for it. This is a very, very common one. TMJ and bruxism are often seen to go together because when you brux, you might be a forward backwards bruxer, but you also might be the side to side grinder. And that side to side motion on the TMJ is a little rough. So a lot of people with TMJ problems are bruxers. And the problem with bruxism is that people don't usually know they do it. So like snoring, if somebody snores, anybody who sleeps anywhere in their vicinity is aware that they're snoring. Bruxism, in children, sometimes it's very obvious because you'll hear them squeaking their teeth. And so a lot of times parents know that their kids are grinding. Clenching, not so much. With adults, it's not always so obvious. And clenching, I think, is a little more damaging. So I have a retainer that I have to wear after all the years of braces that I had. I have a retainer I have to wear, and it covers my teeth. And so when I put the retainers on and I close my mouth, the retainers actually keep me partly open. And when I first started doing it, it really annoyed my TMJ. And I would find that during the night, I would clench all night long. And I'd wake up and my muscles would be sore. So it's like I'm fixing my teeth and keeping them straight, but I'm screwing up my TMJ and I'm making my muscles mad doing this. And so I finally told my wife, I was like, I know I need the retainers, but they're really irritating my jaw because I'm in an open bite. And she said, well, how about this? Wear the upper one night and wear the lower one the next night. And it's funny because just by taking one of them out and just wearing one, that was all I needed, and then it makes it so I don't clench. So that tells you that the TMJ is very sensitive, and the more open it becomes, the more it wants to return to that normal position. And so if it's being held open, it tries to clench down and bite to get there. So clenching is going to mess up the TMJ, and yet clenching is something we can't necessarily fix because it probably has to do with something involving their teeth or something like that. And so that's why I learned that really the best way to deal with these was with a team. So I could always pick my wife's brain on the dental side. I had an orthodontist that I could work with, and then I could do what I do. And in fact, when I can adjust things, and then the orthodontist can make a splint to hold, it actually kind of helps them to heal a lot faster, I've found. And you can take on a little bit tougher cases that way and still get good results. Also, poor posture, stress, arthritis, and gum chewing can also affect TMJ. So in the case of James, his symptoms were a little more severe, and I'm sure it had to do with the dentistry that he had. He had headaches, and these weren't just headaches. He had massive headaches. He had difficulty sleeping. He had a full body muscle weakness, so he feels the muscle weakness all over his body. And so this is what I first started relating to cranial nerves, is that he was getting some kind of a feedback where it was not just some spinal nerve causing pain to its end target. It was feeding back, and it was just messing up everything and really affecting him. He had intense facial pain. He kept telling me he was unable to focus on tasks, and he couldn't really recognize if he was just really distracted by the pain or if there was something else going on. He had difficulty reading. He said his eyes were bugging him. So you'll see two of those in here. So he had, at the very end, he had pre-syncope with sun exposure, but he also had difficulty reading. It relates back to the eyes. This is something that Denny O'Hara talked about when he talked about his Castle Hill kids or his 100-mile-an-hour kids, how they had nearsightedness combined with low blood pressure, combined with hypoglycemia. And what that had to do with was the fact that in the case of presbyopia, the nearsightedness, that part of the eye does not have sympathetic and parasympathetic innervation. I believe it only has sympathetic, whereas the pancreas does not have sympathetic and parasympathetic. It only has parasympathetic. So what he realized over time is that what was wrong with these kids is that they had an elevation of both sympathetic and parasympathetic. And so we commonly think if sympathetic goes up, parasympathetic goes down. If parasympathetic goes up, sympathetic goes down. And one of the things that we're coming to see, in fact, at the extravaganza, I talked to David Geary about this, and he said it's one of those concepts. He said, I really want people to lose the concept that one goes up and one goes down, and that somehow they balance off of each other. He said it's not true. He said think of them as two independent systems. And so what typically happens is you could be hitting the gas and the brake. And so, yes, when I hit the gas, I usually don't hit the brake. And when I hit the brake, I usually don't hit the gas. But it's perfectly possible for me to hit the gas and the brake at the same time. It's also possible for me to hit neither and just sit there. So he said you have to recognize these different possibilities. And so what we get in some of these kids, the Castle Hill kids, what I think might have even been happening in James, is that he was getting sympathetic and parasympathetic both being elevated at the same time. And so that's a bit of a problem, but it's a different neurological picture that we don't think of. And so it's one that you have to start looking for when you get to some of the more complicated or more unusual cases, is that you could have elevation of the sympathetics and elevation of the parasympathetics. And then because some organs only have one innervation or the other, it makes a very confusing picture. And that's why Denny was originally confused with these kids, but eventually figured out by studying the neurology that if you have them both elevated, but you only have parasympathetic supply to that organ, well, then it's going to show like a parasympathetic increase, which would make you think a sympathetic decrease, but that's not true. It's also increased. So that's the basic gist.
Dr. Fowler, real quick. So what's your case management like when you have both being hyperactive at the same time? So you're saying there's a threshold. It's not one's high, one's low. There's the threshold, and then once you go over it, you can go over with both systems at the same time. But how do you case management that?
So typically you're going to have, that would mean you would have somewhere, most likely you'd have a sympathetic subluxation somewhere, and you'd have a parasympathetic subluxation somewhere. And the rule of thumb, this isn't like an absolute, like you have to do it this way, but the rule of thumb based on experience is that if you have a sympathetic and a parasympathetic, you want to do the sympathetic first, because it seems easier to rev them up and then use the parasympathetic one to bring them back down. It appears that if you do the parasympathetic first, you might stall them out so badly that when you go to hit the sympathetic, they just can't kick in and can't go. Like if you think about it like an engine. If the engine's dead and it's been sitting there not moving for a long time, sometimes it's really hard to get it started. The same kind of idea seems to happen with people. So if you let the parasympathetic get them down so low, it can be hard to get the sympathetic to fire them up and go the other way. Whereas the sympathetic, you can fire them up, and then if they get too high, you just use the parasympathetic and bring them right back down. So the typical case management is if you have both problems going on, you want to do the sympathetic first, and then you want to do the parasympathetic after that. So you want to on top. However, if you have two segments in the same area, like two thoracic, you want to adjust the superior thoracic and then do the inferior thoracic. You don't want to do the inferior and then the superior. So backwards. If that makes sense.
Okay. No, that does. Thank you very much.
So that would be basic. The next time I actually want to do a podcast talking about this whole concept of double subluxations and both being revved up and that kind of a concept. I might also talk with Dave Geary about it as well.
Yeah, that'd be amazing. Thank you so much.
I remember this. Oh, I remember what the slide's about. The anatomy of the TMJ. I've found in adjusting that the quality of my adjustments are directly proportional to the accuracy of the image I hold in my head of the correct anatomy. And I think a lot of times when it comes to the TMJ, maybe we don't know the anatomy quite as well as we should. Because one of the things about the TMJ is that there is a disc in there, yes. But on this particular slide, I wanted you to see the ligament attachments and even how the muscle attachments, how things hook in there. But what we don't think about is the disc. It also has a mobile surface above it and below it. So this is what makes it complicated, is when you're trying to set this thing in place, you're trapping a mobile surface next to a mobile surface next to a mobile surface. And so it always feels like, well, I need to pull I to S, and I need to really drive that thing into the fossa in order to really trap those so that I can move them. And as I'm going to show you, that was a concept I held for a long time. It's a wrong concept. So if we just look at a picture like this and we see how it fits in, we would think that that's what we needed to do. And I'm going to show you that that's not what we need to do. We need something different. And it works really well. And I think that might be one of the reasons. Sorry, I apologize. I cough a lot, especially as I'm still getting over COVID, but I also live in California. So we have forest fires all around us and it's very smoky. So the two are not a good combination. And so that's the general idea of how the disc fits in there. This is a video, and it's not going to let me play it, and that's okay. I'm going to tell you where to find it. On YouTube, there's this video, and I was first introduced to this video at a dental seminar my wife made me go to, and I was glad I did, because when they showed me this video, I was like, oh, that's gold, because they didn't even show us the whole thing, so I went back and watched the whole thing. It's a video on the TMJ, showing its movement, showing how the disc moves. And this was another concept that I thought, I bet a lot of us don't really understand how the disc moves as the condyle moves. And so to really understand the movement of this, you have to find this video. People are, and so they have very thick accents. And so when they say the word joint, it sounds like yoint. So the video has been affectionately labeled as the yoint video. So if you go to YouTube and you put into the search the yoint video, you'll get the yoint video and you'll be able to watch this. And they both give a little introduction, which to me was pretty hard to understand. Their English had a thick enough accent that I was like, I'm not totally sure what they're saying, but you get a little bit out of it. And then they go through and they show you these videos of the disc moving, and you can see how it moves posterior and anterior. You can see normal motion, you can see abnormal motion. It's a great video for really understanding how the disc moves. Oops. So here's a drawing that I think better shows it. You can see that upper joint and the lower joint hinges, and they actually move differently. So it's very tricky trying to get this in there. And it also brings to mind when I was in school, we were only taught one TMJ adjustment, and it actually was to get onto the angle of the mandible and to thrust towards the mentum of the chin. So you're thrusting down and you're actually opening the TMJ. I know some people still do this. From everything I've studied and everything I've seen and everything I've learned from the dentist and orthodontist, that might be the most catastrophic maneuver, even worse than pulling up on somebody's occiput, like a Y strap or something. Even worse than pulling up and taking an occiput out of its little dish it sits in would be to take a TMJ and pull the condyle away from the temporal bone. That is, once it comes down, that disc is going to shift. Also, this disc is very, very dependent on ligaments. We'll talk about those in a second. There's some very key ligaments that hold this all together. And one of the things about the disc is when the disc clicks, when you have somebody who opens and closes their condyle and the disc clicks, most likely that clicking is due to the fact that they've torn one of those ligaments. And I equate it to tearing your ACL. So if you tear your ACL, no, you can put it. Your knee's going to floppy and it's going to make noise. People would like to have a normal motion. Well, this is very much akin to that. The only difference is repairing that ligament is extremely complicated and almost nobody will do it. It's very difficult to find somebody who will do it. You can't just go to anybody and have that ligament repaired. So most people who have torn that ligament then are going to live their life with a torn ligament there. So when people come in and they say, my jaw clicks when I open and close. Okay, I just tell them the jaw clicking is due to a torn ligament. That's going to make noise and it's going to make it a little sloppy, but that doesn't mean we can't make it work right. So truthfully, the clicking and the function are not totally related. So I can fix their function and they'll still have clicking. If the clicking annoys them, well, I'm sorry, maybe you need to hunt for somebody who can fix that ligament because that's really the only solution to that. And I'm going to show you some of these ligaments in a second and show you how they would get torn, but they do tear very easily. And that's really what holds this all together.
Hey, Dr. Fowler,
Yeah.
Can you repeat what you were saying? We have a couple of professors at Palmer, Florida that do they thrust down and away from the condyle, from the temporal bone? Can you just explain that one more time to us?
So the condyle, what you have really, and I'm getting ahead of myself just a little bit here, but my next slide is going to get into it, so I'll just start now. What really holds the disc in is there's a vacuum capacity, kind of a suction created by a vacuum that's in there. And that's what holds the disc above the condyle in that neutral position. And so it takes two things to misalign it. It doesn't always take two things, but two things can potentially misalign it. One would be to tear the ligaments. That will allow the disc to start to move excessively. And then if you take the condyle on the temporal bone and you move them away from each other, that disc now has the opportunity to move. It can move anterior, it can move posterior, it can actually move medial, it can move lateral. So it can move almost anywhere around that condyle. And I've seen videos of discs moving in all these directions. And when I first saw the one going medial, I almost had a heart attack because I thought, well, if they go medial, how am I going to fix that? I don't know how to draw it lateral because I can't take a condyle and just shove it across. So what do you do with a medial one? Well, I came to understand that it's all held in by these ligaments and this suction capacity. So if you sever the ligaments and you break the suction capacity, that disc can now go pretty much anywhere. And then once it's there, when you take that condyle and you shove it down towards the tip of the chin, when you let go of it, it's going to snap back up and it's going to trap that disc wherever it's gone. And you've basically just created a misalignment. So do you get cavitation? Yes. You often get cavitations when you create misalignments. In fact, broken bones make really nice cavitations as well. So that's one of the reasons I'm not okay with cavitations, because if you have 6 sounds, it's pretty easy. I had a patient who was skateboarding and fell and rolled his ankles and ears. And he loved to describe the sound to me when he broke it. Well, it wasn't because he needed it so badly. His whole leg turned purple. So that's the whole idea, is that this is in help there. We don't break the suction. We actually I never felt like my adjustments were as good as they should be, but I couldn't figure out how to make them better. Then Josh Lawler sent me this slide. He actually sent me several of these, but he sent me this one. And at the extravaganza, they had these up in the room where all the vendors were. They had them all in frames, and they're actually quite large. They're huge. Josh told me that Dr. Gonstead had these drawn up because he wanted to have a very simple cartoon that explained in very simple terms how to do the adjustments. And so I started reading through this one, and I was like, yeah, that all makes sense. That's how I do it. And then I got down to level 3. And on C, it says, flip the wrist so that the left hand pisiform slips under the left jaw, then press inferior, then superior. And I was like, wait, inferior? Nobody's ever told me that before. So then I thought, well, why is that not in the chapters? So I went looking in the chapters, and I believe it's page 280 in the upper left-hand corner, and it's like one of the last things it says in the section on TMJ, and it says that the adjustment is made by pulling posterior and inferior. And I was like, wait a second. I've always done it the way I was always taught it, the way everybody I knew did it, was they pulled posterior, and then they pulled superior and tried to drive the condyle back into the fossa. But this is saying not to do it that way. So I studied this a whole bunch, and I was like, so what is happening there? And that's when I kind of dawned on me, we're not trapping it and driving it. It's not like the normal kind of adjustment we might do on the spine, where we want to kind of trap the disc and get it pinched in there and then drive the bone to the right position, and by doing that, suck the nucleus to the middle. This is similar, but a little different. By dropping it inferior, you're going to gap it, and you're going to make a space where that thing can go to the middle, and then you're going to take it up. So when you think about that, you think the people who are driving it down, they're doing the first part of the adjustment where they open it up and they give it a chance to move, but then they're not doing the second part where they actually reposition it where it needs to go. And so that adjustment is never going to fix that. It's just going to open it, and then potentially, if you're not controlling the adjustment, driving it down and just driving it could cause greater misalignment because you're not really controlling it. It'd be like applying an adjustment, but you have no regarding for listing. So if you just said, they've got a T7, I'm just going to push on it, and you had no listing, well, there's a chance if you pushed like a PRS, but they actually had a PLS, you could drive it and make it worse. Same thing can happen here. if you drive it down with no regard for the actual listing or what you're doing, you could make it worse. And so, so after looking at all this and realizing it had everything to do with the vacuum capacity of it, which I didn't really know until the first time I tried it. So then I thought, okay, I need to do this on a couple people. So the first one I did it on, it says pull back a third of the way posterior. So I pulled posterior till I was about a third of the way, and then I used my thenars to traction down. And as soon as I did that, I felt the jaw open, and I could feel the disc starting to move. And I pulled it down, and as soon as it shifted in, I flipped around, and I pulled up superior, and I set that thing right in place, and I could feel it drive right in. And I realized that it wasn't about inferior or superior, it was about both in combination at the right time. Inferior, then superior. So after doing it once and the feel I got, I then understood I was using a vacuum, a suction capacity to suck the nucleus in. And that's why in the end, even if it went medial, I can get it back. If I was trying to drive it, I'd have no way of driving it from medial to lateral, but I can suck it from medial to lateral by opening that up and using that vacuum capacity to suck it to the middle, and then it sets in. So I started doing all my TMJs this way, and night and day difference. Like I would have said, I'm a mediocre TMJ adjuster. I do a fair number of them. I get mediocre results. Sometimes I get great results. Sometimes I get no results, and I got a few things in the middle. Now I'm fixing things right and left, things I never thought I could even fix are getting better by doing it this way. So apparently Dr. Gonstead knew what he was doing. Just somehow it got lost in translation, and I didn't get it till now. So that's how I've started doing these. And like I said, it makes a world of difference. It's just developing the coordination that you're going to pull posterior and then use your thenar to drive inferior before you pull back up superior.
Dr. Fowler, how far from the temporal bone is the condyle when you're pulling inferior and then superior? Is it far away, or how close to you before you do it?
Your hands aren't very close to it, and you're not gonna see it move or anything. You just feel it. And you feel. I don't even know how to describe it. It's one of those things you probably have to feel to know that you felt it, but then you have to feel it to know how to do it, but you have to know how to do it to feel it. So probably another one of those horrible conundrums we run into where you have to do it to know how to do it, but you can't do it because you don't know how to do it. So
I just didn't know how far open the mouth is. We start to pull superior. I don't know if it's like very, very short, inferior than superior, like it's a short distance, or is it a longer distance with the mouth open?
So can you only see my screen right now, or can you see me too?
We can see you too.
Okay, so I'll show you. You'd open them like this, and my hands are down here. So my thenar is up here, close to the condyle, but definitely not on temporal. So I want to be on the condyle, but I want to be close to it. And I'm up like this. And as they start to close, you have to tell them, I've found you have to tell people, close slowly. Like, not slowly, really, really slowly. Sometimes I'll use the phrasing, close your mouth as slowly as you can. Because I'd rather them go too slow than too fast. And as they slowly close, then I can gauge that I'm going to pull with my fingers posterior until they're about a third of the way shut. And then at that point, I'm still going to hold with my fingers, but my thenar is going to shove down this way. And as it tractions down, that's when I'm going to feel that change. And I'm going to traction down primarily. Usually it's one condyle or the other. So the condyle that's the affected condyle, that's the one I'm going to pull down harder on. And the other one might traction a little bit to give it some help, but it's really stabilizing from the other side. And then once that drops, as soon as it drops, I'm going to have them close just a little bit more, and I'm going to flip around. And this is the hard part. My hands are going to make this kind of a motion. I can't back off, I'll lose it. So once I've got it there and I've tractioned it down, now I'm going to do a scooping, almost like an AS occiput scooping, to scoop it back up and drive it back up into that joint.
Okay, so it's actually pretty short, your inferior than superior. It's not like the mouth is wide open.
It's a very short stance, and they're going to be at least a third of the way closed. And a lot of people who have TMJ problems don't open that wide to begin with. So that's one of the problems. They only open a little bit maybe, and they say close your mouth, boom, it's over. You're like, well, that wasn't enough time to do anything. So that's why I need to go super, super slow so I have time to maneuver as they go through and feel that through jaw.
Okay.
Do you tend to do both at the same time, or do you prefer the side of the primary alignment first and go to the other side, like stagger the right and left or left and right?
I'm typically going to do the side that's misaligned because, like I said, it's usually one, not the other. In fact, I haven't even talked about the EX listing yet, but I'll talk about that in a second. So typically one condyle is the problem. And so that's the one I'm focusing on. But as I'm doing that phase of pulling down, tractioning down, sometimes they can be really, really stuck. So I use my opposite hand to traction down just because I need a little bit of extra oomph, just because it's stuck so badly. Now, I don't always do that, but sometimes I start to traction down on that side of contact, and I just realize I'm not getting very far. I need a little extra oomph. So that'll do it.
So you set both at the same time instead of because I think Paul's asking because sometimes when we do it, we put the say the right side's the good side, the left side's the bad side. We set the good side first, the condyle on the disc, and then we'll focus on setting the left in. And you're saying you're doing
I don't usually mess with the good one.
Okay.
I usually let it be. I mean, I'm not saying that's right or wrong. I don't usually mess with the good one.
Sometimes we close the mouth slowly, but make sure the good one gets in first, and then do the one that's misaligned. But you're saying really just focus on that left side, have them open and close, and get it done. Yeah,
I usually do that one because what might be happening is because sometimes you'll feel like it's both sides. It's really not. But what can happen is that EX misalignment will torque the opposite side. So then your good side will feel like it's restricted. But it's because of what's happening on the bad side. And if you fix that, then the good side becomes good and works just fine. Now just set the AI portion of the bad side and it's good.
Okay. Thank you.
Okay. So here's a good example. So on the left is my AI TMJ contact position. And on the right is my EX TMJ contact position. I have to do both on him. And you can see how subtle the difference is. The other subtle thing is that on the EX TMJ, I'm not moving with him. I'm actually just holding pressure with my thenar. He's closing his mouth. So what the EX is you put your fingers on the condyles, and as they open their mouth, you'll feel one of them push out, and it wants to swing out this way towards you. If you look at them from the front, you can usually see in their face, both their jaw and their cheeks, you can see that one side is wider and one side is narrower. I did this on somebody not that long ago, and so I was talking to her, and I said, do you have a problem with your TMJ? And she's like, yeah. And I said, is it on whatever side it was? And she's like, yeah. She's like, how did you know that? And there was somebody else standing behind me, and I said, look at her face. You see the asymmetry? And they're like, yeah. So it's not that hard to pick up on, but it'll start to rotate just like a pelvis would do. And so you get one side wide and one side narrow. And so that was because she was flaring around. And so in that case, so the one on the left here, my thenar is on the condyle head, and I just apply a lateral to medial pressure, and then my right hand is stabilizing kind of like I would for a cervical, is all it's doing. And so it's pulling his head, so that's what I'm pushing against. I push the other condyle head in, and then he slowly closes, and typically it hits a point, and it goes thunk, and it drops in. And that EX component, as it flares out on that side, would, at least theoretically, draw the other condyle IN, and then that would make the good condyle feel like it was restricted. But it's actually not misaligned. It just has to follow the other one. So as soon as that one pops in, and I put these in the wrong order because the EX is the one I do first. So I do the EX first. Once that pops in, he usually goes, oh, that's already so much better. Because one of the things about the EX is like anything else, your body wants to compensate. So it often leads to a lot of torquing. And I'm going to show you in a second why it torques the most and why the spine gets involved and then why that spinal involvement leads to cranial nerve involvement. But first, just dealing with this, that gets the EX component out. Then I go to the one on the left where I do the AI adjustment. And I'm close to his condyles. I've got my fingers down there. My thenars are where I want them, and as he starts closing, I can traction posterior, I can push inferior, and then I can bring it back up and set it in. It's very, very subtle, and if he didn't have a beard, I think it would be a lot more obvious. But if you look pre-adjustment, if you look at kind of like the bottom right corner of his bottom right corner of his beard, the post adjustment looks like he got a little bit of a trim. Right? If you look at his beard, it looks like he got it trimmed a little bit. And I had my associate take the picture. The pre-adjustment was taken right before I did the adjustment, and the post-adjustment was taken right after finished. So like he got this little trim. And if you look at his cheeks next to his nose, you notice they're a lot less inflamed. That's because of the TMJ flaring up. So it's very, very subtle, but there is a difference between the two. And so I was just curious to see what it was. And so that's why I took the pictures, because I was just curious, always curious. It affects how the muscles around C2 are functioning on a regular basis. And one of the things the body will do to protect it is to pull out the cervical curve. And so when you get somebody with TMD, a lot of times, like if you just think, I always use this analogy of Caveman Chiropractor, who just sees things that are misaligned and wants to beat on them. So if you look at somebody who's got, they've got a TMD problem, but they have no cervical curve, and you're like, well, first I want them to have a cervical curve. I'll just hit the atlas, or maybe I'll pound the middle, C3, C4, and try to make a curve. Or maybe I'll just do C7, that should bring back the curve. Well, none of that really works because the TMD is playing a part in this. So it's part TMD, it's also part C2. And so you have to look at both of those. However, so I've had, and all the doctors in the room when I presented this agreed with this, they all have too. I can tell you a situation where I had somebody with TMD where they didn't need a neck adjustment at all. I had another guy, he was sent to me by the same orthodontist. The orthodontist, he came in and he said, the orthodontist said he couldn't help me. And I thought, well, that's really weird. He never tells anybody that. Like, he'll always try to do something. He can't help you. He said, he can't help me. He can't find anything wrong with my TMJ. So we go through it. I palpate it, do the whole thing. He's got clicking. He's got popping. He's got abnormal motion. It's not working. So his left TMJ is giving an issue. And I said, okay, well, indulge me for a second. I go around, I scope him, and I palpate his atlas, and he's got a left atlas. So I just told him, I said, I need to set this atlas first because I need to get a good foundation in the spine before I do your TMJ. Okay. So I set his atlas. And as soon as I'm done, he starts opening and closing his mouth. And he goes, it's gone. And I said, what's gone? He said, the clicking. So I palpate his TMJ. All the dysfunction I was feeling, all gone. And it was just from doing an atlas adjustment. So anybody who's done a lot of TMJs will tell you they've got patients like that, where they fix the whole TMJ problem just by doing an atlas adjustment. So we get all of those. The atlas plays a role. The C2 plays a role. The TMJ plays a role, and I think that that's the reason why this joint is so complicated, because I can't think of too many others that are like that. Maybe in the pelvis, where you've got to make sure that L5, ilium, and sacrum are all happy together and that they're working well together. That might be the only thing that's close to this relationship between these joints, and it has a lot to do with this quadrant theory of Gouze that understands that the motion is somewhat abnormal, and it seems to me it's odd that the axis of rotation is not at the condyle, it's not at the condylar joint, it's at the C2. So kind of an odd thing to find. So here's an example of that drawn out. So you can see here that as the jaw opens, if you look at the one on the right, as the jaw opens, its pivot point is right on top of C2 there. And that actually as your jaw opens, we'll talk about this here in just a second, in fact, pretty quick. But there's an element of head nodding that has to happen. It pulls the head down, it pulls the head up. Let me get rid of this stupid hide button so you can see. So if C2 is dropping into flexion, and in this case, if you have TMD, so remember subluxation compensation, if you got TMD, you've got hypomobility of the TMJ. That results in hypermobility of C2. So C2 is going excessively into flexion in a TMD situation. Well, anterior translation of C2 affects the function of the nodose ganglion of cranial nerve 10. So now the vagus has been drawn into this equation. And vagus, at the last Meeting of the Minds, I gave a whole long presentation on cranial nerve 10 and dysautonomia and all this kind of stuff. So that in itself, and polyvagal theory, so that in itself is a whole issue. But to keep it somewhat short, the simple way to think about it is that if we're talking polyvagal theory, then we're understanding that if the vagus nerve is involved, we have both motor issues, we have sensory issues, and we have, I don't even know what to call it, psycho-emotional issues all linked together, right? So that would be the 2-sentence synopsis of polyvagal therapy. Dysautonomia can be created by anterior translation of C2 or by rotation of the atlas. So that's why they both have to be checked. So anytime you've got somebody who has a TMJ issue, you want to check both C2 and the atlas, because they're being pulled into that. And this is not cookie cutter. They're being pulled into it because that's the motion of the joint due to the fact that the axis of rotation is at C2. And because of the odontoid, anything that affects C2 is going to affect C1. So if C2 is drifting forward, it's going to take C1 with it. So either one of them can be the issue. If the right vagus is dysfunctional, you're going to get heart symptoms. And if the left vagus, you're going to get digestive systems. And that's purely a clinical finding. We had this discussion as well, that neurologically, can you explain that? No, but clinically, can you say that it's true? Yeah, you can say it's true. So left vagus is going to be, left vagus for atlas is going to be an ASLA or an ASRP. Right vagus is going to be an ASRA or an ASLP. Both of those are going to rotate the TP forward and put pressure on that part of the vagus, because the vagus is right in front of the TP of atlas. The oversimplified view. We cannot think that TMD is synonymous with upper cervical subluxation, because in the past there's been a lot of people who said, oh, it's not really your TMJ, it's your upper cervicals. If we clear your upper cervicals, your TMJ will get better. Not true. The TMJ, as we've seen, can have its own issue. But this is why there's that strong connection between the two. So we do need to clear the upper cervicals, but you can't say that clearing the upper cervical is going to fix every case of TMD. Hypermobility compensation of the upper cervical spine is a major contributor to TMD. So the reason this is a big deal is that, generally speaking, we tend to approach things from, well, if it's compensation, then it's hypermobility, so we want to stay away from it. But along with that comes the idea that if it's just hypermobility, it can't be causing symptoms. And the issue here in the upper cervicals is it's a very unique area where hypermobility of the upper cervical spine can cause tremendous symptoms, both through the vagus nerve and through contributing to the TMD issue, making it worse. So another implication of this is that over-adjustment of the upper cervical spine will make this condition worse. So you just keep adjusting the cervicals over and over and over and over. And if they've got an issue with the vagus nerve caused by this TMD, that adjustment is not beneficial. It actually is going to make the condition worse. So it's something we don't want to do. So we don't want to over-adjust things, but if they need to be fixed, we want to fix them. So again, this brings us back to find the subluxation and accept it where you find it. Which we want to do is, if we've got upper cervical compensation with the TMD, we want to take away the body's need to compensate. So if it's an upper cervical compensation caused by a lower cervical subluxation, then we want to fix the lower cervical subluxation, be it a C7 or a T2 or whatever may be going on down there that's causing it to go into a flex position and be compensatory. On X-ray, give us that ducktail appearance of the diverging lines. If it's the TMJ, then we want to try to get a good adjustment of the TMJ, get it freed up to move, and that's also going to affect how those upper cervicals are functioning. And if we can fix the subluxation, then that's going to, over time, help with the hypermobility caused by the compensation, and that's how we're going to stop getting irritation of the vagus nerve as it passes down through there. I now have this new habit of collecting dental cartoons. It kind of annoys my wife, but I think it's funny. So there you go. So moving on a little bit, we're going to change flavor just a little bit. I talked to you before about ligaments and how those ligaments are what holds the TMJ together. There's a few important ligaments. And what's funny about this journey is I wanted to know what ligaments are important. So I started studying these ligaments. Well, I'm going to get ahead of myself. So let's just start with the ligaments and then we'll talk about the muscles that go with it. This ligament in particular is important because there's probably a number of people who have torn this ligament and they have no idea. So the role of the stylomandibular ligament is to hold your mouth shut when you look downward. So you can test it now. Look down. Your mouth doesn't open. If you didn't have the stylomandibular ligament, it would. Another way of, well, we'll get to that. So that's its basic job in a nutshell, is you look down, your mouth stays shut. We've got two syndromes. There's Ernest syndrome, which is pain and weakness at the mandibular attachment. So you got styloid, mandibular. So it's a short little ligament that goes from the styloid process to the back of the mandible. When you have a problem with the attachment on the mandible side, that's Ernest syndrome, and Dr. Ernest was a dentist. If it's on the other side, on the styloid side, that's Eagle syndrome. And it can be either the styloid attachment or the stylohyoid ligament as well, and which affects tongue movement. Dr. Eagle was an ENT. So if you sever the ligament, it'll result in chronic pain and movement dysfunction. Osteophyte formation is a sign of abnormal traction on the ligaments. So you can see osteophyte formation coming off of the styloid process. Sometimes you can see it on the backside of the mandible. When you see osteophyte formation, even in the spine, it tells you that there's abnormal traction on the ligaments because there's a movement dysfunction, and the body is trying to stabilize a dysfunctional joint. And to do that, it's calcifying soft tissue. So it's taking ligaments and it's calcifying it to give more rigidity and try to limit the motion. So same thing here. You sever that ligament, you're going to start getting osteophyte formation on either the styloid or the mandibular side of that thing. So there's a picture of what it looks like. You got the styloid process, you got the little styloid mandibular ligament, and then it hooks in the mandible. So let's talk about what can happen wrong with this thing. So basically what it does is it also prevents anterior translation with mouth opening. So increased anterior translation leads to increased mouth opening. So that's another one you can try. Take your bottom jaw and jet it forward, and then open your mouth. And you should open wider than if you don't jet it forward. Or even better, retract your jaw, pull it backwards so you have like a massive overbite, and then try to open. It doesn't go anywhere. So this is what it does. So when you look at this thing here, you can see that it all fits in a zone. As there's greater anterior translation, there's also increased degrees of mouth opening, or millimeters of mouth opening. So we know that that's what it does. It holds that back. Mechanism of injury. So this is how it would be injured. Eagle syndrome, which is the one on the styloid process, is actually very rare. It's more severe, but very rare. Ernest syndrome is actually very common, and it follows a flexion extension injury, namely a whiplash. So the styloid mandibular ligament prevents excessive anterior drift when we open. So the ligament is pulled tight. You look up, it's loose. So if in a severe whiplash, if you had a severe flexion injury, it's already tight when you're looking down. If you look down far enough, you could tear that ligament. And so that's typically what happens. So that would be, I don't know, we go in our Gonstead class at 11, either whether the initial motion in a whiplash is going to be flexion, which is going to give you most likely a lower cervical injury, like a C6, or if their initial motion is going to be extension, which is most likely going to give you an upper cervical injury, like an atlas. Well, if you get the flexion one, you're going to injure your C6, most likely, but you're also you could potentially tear this. Well, if you think about the distance between C6 and the stylomandibular ligament, it's very possible you could confuse the pain from Ernest syndrome as being the injury to the C6 from the flexion. And that's kind of my theory on why a lot of these get missed or ignored. It's just you have a flexion injury that bad from a whiplash, like a car accident, your whole body's sore, and you just want it all to go away. So you aren't really just defining what hurts here and what hurts there. And so it's really easy for that to get missed. Potential causes for Ernest syndrome are primarily auto accident, whiplash, also blunt trauma, law enforcement submission techniques. That's one you don't usually think about. Another one would be general anesthesia. Primarily that would be from intubation. Dental surgery, which is from keeping the jaw open for a long period of time. I would almost put those two together. General anesthesia and dental surgery, you have to be very careful to make sure that the jaw is only open so wide. When my wife does dental surgery under anesthesia, she uses very particular equipment to make sure that the kid's jaw is protected and all that kind of stuff. Some people do it, some people don't. It's just something to be mindful of. So when a patient comes in and gives you a history that involves dental surgery, and they might tell you, oh, they put me to sleep, and when I woke up, I was in a lot of pain, that kind of thing. It's not for nothing. It doesn't mean that's definitely what caused it, but it's worth at least keeping in the back of your mind because it could potentially be what caused it. And excessive yawning, or I would say extreme yawning. And this is a prime ligament and not an accessory ligament, which means it can be subjected to a hyperextension injury. So that means it's not just from the hyperflexion, it's also a hyperextension. So a whiplash you go hyperflexion and you damage that ligament. Then you go into extension and you re-damage that ligament. So it's getting beat up in both directions. That's another reason why it can be susceptible to that. If it shows up, it usually begins as tenderness below the earlobe, similar, wisdom teeth. In later stages, it includes pain in the mandibular molar teeth. So it might be mistaken for molar pain. And they'll be thinking, did I hurt one of my teeth, or do I have an infection? And they can be totally off track because it'll show up that way. Then you get pain and fullness in the ear, then throat soreness. You can see from these symptoms, it would be easy for the patient to think they have a bad tooth leading to an infection. And it's not. It's actually that ligament that tore. Then they get the TMJ condyle pain at the coronoid process and zygomatic arch. I mean, by the time you got pain in your zygomatic arch, if you're still thinking infection, that's one heck of an infection. But if it's not red, swollen, puffy, anything like that, it's not an infection. It's most likely this. Then you end up with temporal headache, eye pain, and photophobia. Which photophobia takes us back to the situation with James and his eyes, once again. So what's that popping sound? I already talked about this a little bit. It has to do with the ligaments in there. But the dental model of TMJ is different from, I would say, our traditional model. I should have said our traditional model. Our traditional model is that all TMJ is due to damage or dysfunction of the disc. And that's kind of a traditional model that does extend beyond us, so that's why I put it that way. But in the dental model, is that ligament damage causes asymmetrical movement. So on closing, some teeth will touch before others. So if you have a high filling, or you have a crown that was built up a little too high, so as you're closing, you don't have this nice simultaneous timing of the closing. You hit one tooth. All that force is going into that tooth first. So that means that TMD is ultimately a timing issue. Some of these require adjustment of the TMJ. Others require dental care to affect the timing of the teeth touching. And then still others have ligament damage. So the reason I put this all together was to get people to realize that you've got a patient with TMJ, you cannot assume that there's just one cause of that and that they must have had some kind of damage or dysfunction, that maybe they slept wrong. I've had people get it from sleeping on their arm, and then because they sleep like this, the weight of their head pulls down. I've had people do that. That's not the only cause. It could be a tooth timing issue, which could be the result of dental care, or it could be an indication that they need dental care because they've got a problem. You need to go see somebody. And then it could be that they had a bad car accident sometime in their past, and they don't even associate this problem as being caused by that problem that was in their past. Now we're going to shift again, because once we start getting into this area and we pull in the bruxism and we pull in the polyvagal theory associated with the cranial nerve 10 that was affected by the C2, that was the axis of rotation for the TMJ that's not functioning correctly. You see how complicated this gets? That was kind of the point. And I wanted especially the experienced doctors to recognize that it's not you. The problem most of the time with TMJ is that we've been oversimplifying the entire thing. And it actually is very complex with multiple things happening simultaneously. So what I'm attempting to do is extract them and look at them individually, but really they could all be happening simultaneously, or they could not be happening simultaneously. We don't really know. But the research has established a link between TMD, bruxism, and sleep disordered breathing, although we don't know exactly how they're connected. Is bruxism caused by sleep disordered breathing, or does sleep disordered breathing cause bruxism? The answer may be both. So it could be one could precipitate the other in anybody, and then the opposite could also be true. What we do know is that if you have bruxism, it is likely that if you don't do something about the bruxism, you will eventually develop TMD. So you may not have it now, but it's kind of an inevitable down the line thing that will happen. Between 1.2% and 5.7% all children have sleep apnea. Let's talk about child sleep apnea. Well, I have this one, so I'll start with this one. OSA, which is obstructive sleep apnea in children, is often confused and misdiagnosed as ADD. So when children have sleep apnea, it tends to amp them up. They become very fidgety, moving. They basically are so exhausted that they move to keep themselves going. My son doesn't have this, but my son has this habit at night. We can always tell when he's getting tired because he starts moving and running. He wants to run through the house. He wants to climb on things. And as soon as he starts doing that, we go, okay, you need to go to bed because you're both active and sleepy, and the chances of you falling and hurting yourself are really, really high. So that's usually when we go to bed. It's almost getting to the point where he starts to recognize it himself. So that's just a natural tendency of children. So these children are so sleep deprived and they're so tired that they get diagnosed with ADD, and then they put them on ADD meds, which they don't need. And so it's actually, for the people who deal in this area, it's really amazing when you start working with kids with sleep apnea and you start having some who have been diagnosed with sleep apnea and ADD. And as you fix the sleep apnea issue, the ADD goes away. It's because they never had ADD. It's because it was a symptom of their sleep apnea. Another thing my wife taught me is that in adults, when adults lose their airway from sleep apnea, it's from vertical loss. And there's I think I have it in here, the Mellon potty test, where you look and see the uvula and how far it hangs and how much you can see and how much the tongue obscures it. So it's in here. We'll talk about that with adults. With children, they don't lose it vertically. They lose it horizontally. It's the adenoids that come in. It's other things that come in. And it takes away their horizontal airway. And so this is something to look for in children. And so I've gotten to where when I start going down this path, if they've got a lot of people who have TMJ, I actually will have them open wide, look in their mouth, and most of them are adults. I haven't done really that many pediatric TMJs. But adults, I'll have them open their mouth, and I will evaluate their melon potty, and I will look to see if they have bruxism. I'll ask them about bruxism, but I'll look to see if they have signs of high risk of sleep disorder breathing and see if I can start tying those things together. The neurology of sleep disordered breathing is very interesting. So I started looking at these things, and I started looking at these muscles. Inside the mouth, mouth anatomy, it started to get a little complex, so I left it out of this, but mouth anatomy, you can break the muscles into compartments. You've got some muscles that affect the tongue. You've got muscles that affect the arch at the back of the mouth. You've got muscles that affect swallowing. Well, there are groups of muscles that do this. And what's very, very interesting to me, and I don't even remember how I first discovered it. Well, I first discovered it with palatal glossus. And that had to do with a lecture I gave on. And Chris Meyer asked me, do you know what its innervation is? And I didn't. So I went and I looked it up. And I came back and he said, it wouldn't happen to be cranial nerve 10, would it? And I said, actually, it is cranial nerve 10. And that's when he introduced me to polyvagal theory and all this other stuff. So I started with palatal glossus and recognizing it was cranial nerve 10. And I started wondering, does cranial nerve 10 innervate any other muscles in the mouth? Well, yes, it does. It turns out that within these different classifications of muscles, there's these groups of muscles, and one muscle in each group is innervated by cranial nerve 10. So the levator villi palatini is innervated by cranial nerves 9 and 10. The palatopharyngeus, which is a swallowing vocalizing muscle, is innervated by cranial nerve 10. Salpingopharyngeus opens the eustachian tube and swallowing, cranial nerve 10. So you've got patients who have plugged eustachian tubes. Salpingopharyngeus is the muscle that has a lot to do with that. And the uvula itself is innervated by cranial nerve 10. And when it contracts, it elevates the soft palate. So the funny thing about all of these muscles, when I looked up their actions, all of these muscles, when they contract and when they function, they increase the breathing space and they increase the airway. If you have paralysis of them, it leads to a decreased airway and sleep disordered breathing. So this is really kind of the crux of sleep disordered breathing, is a decreased airway caused by paralysis of these muscles, and the paralysis comes from cranial nerve 10. I'll talk about why that happens here in a second. And so then it closes the airway. Another test you can do is asymmetrical contraction is a sign of unilateral paralysis. So keep that in mind. Let's look at that. You can tell. So the cranial nerve 10, because we always say cranial nerve 10, there's actually two cranial nerve 10s, one on the one side and one on the other. It's quite possible and most likely that only one would be affected and not the other. And so if you get this paralysis, the paralysis is highly likely to be one side and not both sides. So you're not really taking your whole airway and shrinking it down to nothing because you'd actually suffocate. But instead you're taking your airway and you're shrinking one side of it. And that's going to make air move quickly one way and not the other. This whole thing. In fact, there's a whole issue about the fact that really when you're sleeping at night, you shouldn't be breathing through your mouth anyway. You should be breathing through your nose. So you've got nose breathers versus mouth breathers. But I've talked about that in a different lecture, so I'm not going to pull that in. But ultimately, you shouldn't be breathing through your mouth anyway. But when you are, and then you change the shape of the airway, you're going to end up with a lot of trouble. You're going to end up with sleep disordered breathing. So I started to wonder, is there an association between obstructive sleep apnea and hearing impairment? Kayabasi found that the association was so strong that the severity of obstructive sleep apnea was predictive of the severity of hearing loss. The original idea, I have here in the second one, was that authors and studies, they decided that the hearing loss that was almost always associated with obstructive sleep apnea had to be due to mechanical damage caused by the snoring. Their theory was that this middle ear was so close to the mouth and they were making so much noise that they made themselves go deaf. And I thought, well, that doesn't make sense because the person sleeping next to them can hear them really loudly too, but it's not loud enough to go deaf. So the amount of noise it takes to make you go deaf, it just didn't seem like it made sense. But the actual common denominator between all of these is the vagus nerve. So I think it's more likely that the hearing loss from obstructive sleep apnea has to do with a neurological connection through the vagus nerve, and it's not mechanical damage to the ear. So here's something I thought was interesting. I'm going to show you a couple slides that I got from Dr. Ross Hauser. I like him. He's got a YouTube channel. He does prolotherapy, which you can listen to him and learn what that is, but it has to do with tightening ligaments, especially in people with Ehlers-Danlos syndrome. But it tightens up their ligaments so they don't have all the neurology problems. But he's a great source of information. Actually, I recommend, if you have spare time, listen to his YouTube channel. So that's Ross Hauser. I can't remember the name of his clinic, but his clinic's in Florida. Anyway, so this slide comes from the different nerve arrangements from the ear. And you can see, I zoomed a little too far, but you can see in that central purple portion, cranial nerve 10 is thrown in there. And so sensitivity can give us a clue as to what nerve we're looking at if we look at sensitivity of the ear. So, just another tool for trying to assess where it's coming from. So here's the uvula deviation. If you've got paralysis on one side, when you have them say "ah," the uvula won't go straight up, it'll deviate to a side. And so the side that works will pull it up, and the side that doesn't work just sits there limp. So the uvula will deviate to the good side. It'll deviate away from the bad side. So we can pull in polyvagal. So this connection between all of these things being connected, from sleep apnea to cranial nerve 10 to TMD, and the cranial nerve 10 being affected by C2, that all brings us back to polyvagal theory and a cranial nerve 10 connection. So that probably plays a causative role in a sequence of events. So research shows that soldiers with PTSD have a much higher incidence of sleep-disordered breathing. This is something I found a long time ago when Chris Myers and I were first talking about this, and I just thought about it because he said, well, people with PTSD are going to should show some signs of muscle paralysis. And I thought, well, cranial nerve 10 is involved with all this stuff. I wonder if they have more sleep-disordered breathing. Well, yeah, people with PTSD have a high prevalence of sleep-disordered breathing. So then I thought, well, then I wonder if they have a higher prevalence of TMD. Much to my surprise, I didn't expect it to be so easy to find. Research shows that soldiers with PTSD have a much higher incidence of TMD as well. In fact, they go almost hand in hand. So then you say, well, what's the connection between these? Because try to think of what could possibly be the connection between TMD and sleep-disordered breathing. TMD is not actually going to change the shape of the mouth and affect how you breathe. Their common connection really is simply cranial nerve 10. So is dysautonomia at the root of both sleep-disordered breathing and TMD? It very well might be. So that leads us to thinking, well, how can we affect cranial nerve 10? Well, we already talked about the fact that cranial nerve 10 sits on the front of atlas. So would an atlas subluxation potentially be at the root of all these problems? It could be if it affected the vagus and then caused paralysis coming from the motor side. So here's the scenario that I came up with, just because I wanted to show how complicated and crazy this could all be. So a patient has a whiplash injury from a motor vehicle accident. The subluxation is then at C7 or T1, and it causes hypermobility compensation at C1, C2. The hypermobility affects the nodose ganglion, leading to dysautonomia of the vagus. Vagal dysautonomia then causes partial paralysis of certain muscles in the mouth, the ones we talked about that change the airway. Muscle paralysis leads to asymmetry of motion with opening and closing. The asymmetrical motion with the aberrant timing of closure leads to a TMD problem. Prolonged TMD causes damage to the ligaments, causing increased severity of TMD. but the patient presents with headaches. And that kind of gives you a view of how a patient can come in and say, oh, I get headaches. And this could be what's hiding in the background for you to uncover, is all this detailed thing. Now, not always, but it definitely could be. And that's when I realized just how complicated TMD was. That to think that I could have a patient who simply tells me in the history that they have headaches, and I don't have any clue that they have all this stuff. If I were to go probing, because I knew enough, I might then find out that they had a car accident. But the car accident that we started with, all of that was 15 years ago. So they don't even think to mention it. And they wouldn't think to mention it. Certainly that car accident from 15 years ago isn't the cause of my headaches, because that's what they think. So it gives you a scenario showing you just how complicated this whole thing can be, but showing you a chain reaction of how one thing leads to the next, and at each chain, it gets a little bit worse and a little bit worse until by the time they have these headaches, these probably aren't just headaches, these probably are really severe headaches, which takes me back to James. His original complaint was debilitating headaches. So that's how we end up there. One other thing I wanted to show you, and I'll go over this pretty quickly. This is kind of complicated. I'm probably going to talk about this in a lot more detail at the Meeting of the Minds, but we've got a long time, so I could go for a long time on this one. But basically all it is this again comes from Ross Hauser, Dr. Ross Hauser. He calls it the blocked brain toilet. But what happens is the cerebral spinal fluid around your brain needs to be able to drain. And if you have an upper cervical issue, it can block that toilet and it can't drain like a toilet. So it's just clogged up. And so if you think about this I think could be a very likely explanation for CTE, because you've got brain trauma. If you look at the left one, you've got that red brain, you've got brain trauma, and then that leaks metabolites into the cerebrospinal fluid. That's why the body needs to drain that fluid to get those things out of there. But if the brain toilet is blocked, which could happen from the same severe head injury that caused the concussion, could also cause the neck misalignment that blocks the draining apparatus. So now those metabolites are left in there and they can't drain. What are they going to do? They're going to irritate the brain. And when they irritate the brain, it's going to produce more metabolites. And you can see how over time, this feedback going back and forth then causes people to act out and do crazy things that are really far removed from the actual injury. It's just this slow buildup over time. And that the solution is to unclog the brain toilet, let that thing drain, and you can make a big difference in that. At this point, totally theoretical, but man, I would love to do some studies on people like this and see if we could do something to free that up and help them drain that toilet. This gives you a good view. If you have any questions about the positioning, you can see that as the nodose ganglion sits right in front of the TP of atlas. So the nodose ganglion's there, the internal jugular vein is there, and the internal carotid. So as that atlas TP starts to move anteriorly due to rotation, or possibly even laterally with the lateral flexion, the lateral wedging that gets, we don't really slide that far lateral. The wedging at C1 is primarily due to the fact that the surface of C2 that it hooks to is a beveled edge. And so as the joint capsule swells, it drives it superior and slightly lateral, but it's not a lateral translation of atlas. So it's not going to trap it that way. It's just going to drift upwards. But that drifting upwards could extend the distance, and it could create a stretch on any of those three structures that are in there. So this just shows you how tightly packed these things are in there. So if anybody thought, well, certainly there's enough space for things to move around. No, if that atlas or that C2 start moving, or if you get an atlas that moves contrary to C2, that could easily put enough pressure on any of those structures to affect how they function. When I first, I'll tell you this story really fast. When I first met my wife, her mother was having a problem because she was told that she had carotid stenosis and that she was not getting adequate blood flow to her brain through her carotid arteries, so she should do everything in her power to not be stressed, because if she got stressed, it could kill her, which is a great way of keeping people from getting stressed. So it turns out she'd been adjusted by a chiropractor who sadly called himself a Gonstead doctor, but I could tell by the misalignment that when he adjusted her C1, he had massively over-rotated it. And so it was sitting, I can probably remember the listing. I believe it was an ASLP, and it was really P, because when my arm was in position, I was almost having trouble getting far enough back because my elbow kept hitting my ribs, and I couldn't get far enough behind it because of how P it was. It was very much a chirogenic subluxation. So, but I rotated it around, adjusted it. As soon as I adjusted it, she's like, whoa, I'm getting some blood in my brain. Well, then went back to her doctor and they said, oh, it got better. It went away. You don't have the carotid stenosis anymore. So that shows you that carotid stenosis was from the rotation of the atlas on the C2. So it's absolutely something that can happen. I don't want to exaggerate and act like everybody's got it, but it's certainly not that situation. But it absolutely could have an extreme example like that one with my mother-in-law. This is basically just showing the same thing from a different view. So you can see where these structures sit. They sit right in front of those TPs. So rotation would get it. But you can see on C2, if C2 was hypermobile with flexion, as it flexes forward, it's going to take that nerve right along with it and put that pressure on it. So that's going to affect how that functions as well. The no-nose ganglion, in case you're unfamiliar with that, is the inferior ganglion of the vagus nerve. It's primarily sensory to the peripheral nervous system. It's located within the jugular foramen, which means it's anterior to C1. It's larger than and inferior to the superior ganglion. It receives cardiac afferent inputs. So that's the connection with the heart. Preferentially, it senses chemical stimuli. And a few elements within it can respond to mechanical stimuli or both, but it is preferential to chemical stimuli. And the various inputs can contribute to symptoms referred to the neck and jaw region. See, I told you I like to collect dental pictures. I told my wife that she should become a pediatric prosthodontist and start doing this to all the babies she sees, but she didn't think that was such a great idea. And then just to finish up, I'll go ahead and include this. I put this in as filler because it was very interesting, and I thought if I have extra time, I can kill some time with this. So I was looking through research, and I found this research on hand skills, basically, and how do people vary based on male, female, right hand, left hand, like what are the hand skills things? So they were doing studies on these people on hand skills test, and the skills they used were square marking, dotting between targets, line drawing between targets, punching holes through targets, and peg moving. So just for the research side, that's what they used. So what they found was the differences between hands. They found that the right hand is more correlated than the left hand. Meaning that the right hand seems to fit into a nice little tight bundle of everybody doing about the same. Left hands can kind of vary a little bit. I think this is presuming that most people are right-handed, so it might just be an uncoordination of the left hand, but whatever. So differences between the tests. They found that moving pegs is easier than dotting or holes. Okay, that's the who cares part. This is the interesting part. Who has better hand skills? On tests with the dominant hand, women perform significantly better than men. So I think this is really great for how lay people look at COVID research and they go, the research is clear. If you looked at this, you'd say the research is clear. Women perform better than men. However, when you actually look at the research, what you find is that when you measure, when measures of the index finger and the thumb thickness are used as a covariate, all of the sex differences disappear. So are they better because they're women, or do they perform better because they have smaller, skinnier fingers? And that's what they actually discovered, is that it's not about men and women. It's about people with smaller, skinnier fingers have better hand skills than people with fat fingers, basically. Right-handed people, this is where I thought it got really interesting, is the right-handed people can improve their left hand by practicing with their right hand. Meaning if you don't think your left-hand adjustments are very good, give more right-handed adjustments and your left hand will get better. But this does not improve their right hand, and the transfer doesn't happen from left to right. So as you're giving these right-handed adjustments, you're getting your left hand better, but you're not actually going to get your right hand better. And if you practice with your left hand, practicing with the left hand will get your left hand better, but it won't make your right hand better. So it only moves from right to left. Kind of weird, but that's a good way to practice. So again, there's evidence that if you practice with your right hand, your left hand will get better. Left-handed people, on the other hand, can improve both their right and their left hand by practicing with either hand. So if you're left-handed, it doesn't matter which hand you're practicing with, they're both getting better. That's kind of awesome. But don't worry, if you think the left-handed people are really lucky, they have a downside that's coming later, you'll see. The right hemisphere of the brain ages more rapidly, which results in left-handed people losing their hand skills sooner. So this is the thing. Left-handed people develop their hand skills quicker because every time they practice, they're developing both hands. But because the right hemisphere of the brain ages more rapidly, they start losing their hand skills at an earlier age, and they have to retire sooner because they don't have their hand skills. So it's kind of a double-edged sword. You get it quicker, and you lose it quicker. The right-handed females have more asymmetric motor function than right-handed males, meaning right-handed males are a little bit better at being symmetrical between the right and the left, making them look pretty similar. Women often are going to have more struggle with their left hand if they're right-hand dominant, because there's more asymmetry between the motor function of the two. So as a female, you really want to work that left hand. So that means using what we already know, practice with the right hand to make the left hand better, and then practice with the left hand to make the left hand better. That's basically how you get there. So don't neglect your left hand, I guess is the moral of the story. If you are a right-handed female, do not neglect to use your left hand and focus on your left hand. So you really need your left hand. As much as you need it for adjusting, you really need it for stabilization. So there's no harm in doing right-handed adjustments, because at that moment you're using your left hand to practice stabilization, and as you do the right-handed adjustments, you're helping your left hand to do better adjustments. So be sure to, but part of the trick is when you do it, let the right hand go. Let the right hand just naturally do what it does. Focus your brain power on what your left hand is doing and that stabilization, because that's going to help you develop those motor skills. All right. We were in Wisconsin, so I wanted everybody to enjoy their flight home and their TSA check. And that is it.
So Dr. Fowler, quick question. How long did it take, how long would you say you would start to see some significant results for someone that has some dysautonomia of the vagus nerve?
I actually, from what I've seen, they can be fast and they can be slow. It's pretty unpredictable. It also has to do with how complex is it. If it's a dysautonomia with a pretty simple cause, you can get a pretty simple solution and get a quick result. If they've got a lot of complexity going on, if they've had it going on for a long time, those tend to be the factors that make it take a little longer.
Rachel asked, have you seen improvement with your patients who have obstructive sleep apnea when you adjusted their atlas?
Yeah, so actually this happened very early on in practice. I was probably in practice 5 years. And I had this guy that he came in and I found an atlas problem and I adjusted his atlas. He was having headaches or stiff neck or something. I adjusted his atlas. He goes away. I don't see him for a couple of weeks. And he comes back in. And I said, oh, is your neck bothering you again? And he's like, no, actually. He said, no, not really. I said, well, what brings you in? He said, my wife made me come in. And I said, why? And he said, because after you adjusted me, I stopped snoring. And when I started snoring again, she told me I had to come in and get it adjusted again. So, yeah, I have seen that happen, that it does change it. So, but it's very particular. It's not like, I think that's one of the hardest things in chiropractic is we don't have a recipe book. Or I've had patients say, I need that adjustment for whatever. I need that adjustment for a headache. There isn't an adjustment for a headache. It's finding the subluxation and fixing it. So getting our heads out of that space and realizing that there's not an adjustment for sleep apnea. There's solving the problem. And then the things just kind of magically disappear because now they function right.
So what do you see when if there's a legitimate subluxation at the atlas and say a legitimate subluxation at the upper dorsals or lower cervicals, and you get results from both kind of, what would you kind of stay more at and try and clear that lower dorsal first before you start going back up, or knowing when to jump around? Like that's the hardest thing. I feel like knowing when to go towards one or towards the other.
Yeah, we had this conversation in our email chain, and Josh Lawler made a very good argument for making sure you have a good foundation. And from experience, I kind of agree with it, that if you don't have a good foundation, you can give the best adjustment to the subluxated vertebra and everything seems great, but you don't get the stability. It would be like having an anatomical leg deficiency, and because you never bring it up, it's like you adjust it and then it falls back out because they have to walk again. They have to chew again. Like it's a very good argument that you need to create a foundational stability first. And so even though you know this is what's causing your main symptom, but I can't start there. And that's actually a really crazy thing when you have a patient, you pull this off and you tell them, I know this is your main thing. It's causing this symptom and I want to fix that. However, I'm going to start down here and I'm going to set a foundation, and you're not going to feel a lot better. And you're going to think that I'm wasting your time and your money, but that's okay because I'm going to build this foundation, and then I'm going to come in and do that adjustment. And once I do it, it's going to take like 1 or 2 times, and you're going to feel like a different person. And then and then you do that and it works. And I've had that happen. And they're like, how did you know that? Well, the dumb thing is, how many times should I have done that and I didn't know that? Like, I don't think about how did I know that. I think about how did I not know that? Like, get that foundation and give it something to sit on, and then it'll actually hold stability.
Yeah, for sure.
And it does save you from jumping around. Once you start jumping around, you start to feel really out of control.
Mm-hmm.
It doesn't take long jumping around. You feel out of control, and the patient starts to be like, you're out of control. You're jumping all over the place. So this way is much more systematic, and it just seems to work better too.
For sure. And this might be a completely different question, but when you feel like an atlas is pretty much right under a mastoid, and it's that superior on that one side and with laterality, what does that kind of tell you when you see that much of a wedge on an atlas?
It just tells me the joint capsule is really swollen.
Okay.
Which they can be, and people probably have different size ones, because you've got the C2 surface sits at an angle, and you've got the atlas. As that joint capsule swells, the atlas moves like this. So it's going superior and slightly lateral. If it does it a lot, then it's going to be right underneath that mastoid. It could also be a sign that the person just has a gigantic mastoid.
Yeah.
Or they could have had mastoids. So some people just have giant mastoids, and so it gets up under there. The only tricky thing about that is to make the adjustment, you got to be on the TP and not on the mastoid. So how do you get it away from there? So you got to wiggle around a little bit and figure out how can I get that TP to separate and make sure I'm just on the TP. And then as soon as you've got the TP, push it lateral to medial and get it away from the mastoid. And then you've got it, you can set it.
Okay, I'm asking you these questions because there's a patient I'm thinking of that has a upper dorsal subluxation and an upper cervical subluxation. And sometimes I feel like I'll jump to that atlas when I see that the atlas is really superior on that one side. And I'll be like, okay, I need to address this because this is just very swollen. But then go back to the foundational and try and get that under control. Do you think that's right, or should I just stay for the foundation?
You probably want to ride one of them for a little while.
Okay.
And in that situation, I would trust tremendously in the scope.
Mm-hmm.
I would let it tell me which one's the bigger problem.
Yeah.
And then I would probably just ride that one.
Yeah.
I think I would just keep riding that one for a while without jumping around.
So how often do you see patients like in a visit and in a care plan? Do you see them 3 times a week for X amount of weeks, or do you start with 2 times a week? Because I feel like we hear contradicting things sometimes. Some people say, oh, I'm fine seeing people 3 times a week for 3 to 4 weeks. And then some people say, I'll never go 3 times a week. I'll stay maybe 2 times a week. What's your opinion about that?
I'm probably a terrible person to ask. So I was doing something with my son and daughter, and my son wanted it shown to him exactly how it was going to happen because he's a total perfectionist. And I said, you want to know exactly how this is going to happen so you don't make a mistake, right? He's like, uh-huh. I said, I get it. I'm that way. And then my daughter goes, I'd like to just wing it. And I said, I know, I'm that way too. So I definitely wing it, probably way too much. I don't have a set plan. So when they come in, I actually am more comfortable winging it and going, and just from each adjustment determines what the next visit's going to be. So okay. It could be tomorrow, and it could be in a week, and it could be in 2 weeks. Like each one just kind of determines where we're at. So I don't really follow, like, because I did 2 days last time, I got to do 2 days again. I wing it. I definitely wing it.
Okay, because I'm in my beginning of my clinical phase, and that's how I've been kind of doing it. Instead of being like, okay, we're set for this amount, I've been like, okay, you're doing better. Let's give you a little more time to see what happens. Or all right, you need to be seen again tomorrow. So that's where it's hard to, I guess, make sense of it sometimes.
I have a patient who she fell down her steps. She was letting her dog out during the night. She fell down her steps, face planted in the cement. Was unconscious, doesn't remember most of it. And then after that was so disabled, she had to quit. She did her worker comp thing, ran out of time. They made her take early retirement. She's sitting at home, early retirement. She's not that old. And fortunately, she's friends with somebody who knew me. And after she had seen a bunch of other chiropractors and other people, they said, go see him. So she came to see me. Her problem was she had a really bad C2. And the C2 had taken the C1 for a little bit of a ride. So we had to adjust the C2. And so I did it primarily at the beginning. My associates did it a little bit. Now Labib's doing it more and more, although she likes having me do it. But I just set the C2, and I just kept setting the C2. And I said, we just got to ride the C2 for a while. Well, the end of the story, to jump to the end, today she came in her uniform. She's back at work, working limited hours. All the problems are gone. But the really funny thing is today I adjusted her atlas. So go figure. And with her, the biggest challenge is actually keeping her away from the office, because she was so bad and now she's so good. If she feels the slightest little thing, she comes in, she goes, it's catching right there. You got to move it. You got to get it off there, because she doesn't want to go back there. And sometimes I actually did it. I think it was when I was in Mount Horeb that he sent me the text. I had adjusted her right before I went to Mount Horeb, and I debated about it, and I was like, I don't really want to do it, but I don't want it to get worse, and so I adjusted it. And while I'm at Mount Horeb, he sends me a text. She came in, she's really horrible today. Stupid thing, I shouldn't have done that. So I know not to do it too much. So even today when she came in, I was like, I'm not going to do it. I was already thinking, I'm not going to do it. And then I scoped it and I palpated it, and it was totally her atlas. And I was like, okay, I'm going to do it. I'm just going to do it a little bit. So I just did a little bit, and it got rid of what was bugging her, and it was moving, and so she's all good. So it moves around, and so with her, she kind of goes, can I come next week? All right, we'll do once a week if that's what you want to do. And we always talk about, I'm just going to check you. I may or may not adjust you, but I'm going to check you. And then we get into our negotiations of her trying to convince me to do something, anything, make something move. So that really, I think, is the hardest part about seeing patients, is that if it really does help them, they will do everything to try to negotiate you into doing something that you might regret down the line, because it's harder to fight the urge to adjust rather than to get in there and adjust. Like, people think, I got to convince these people to let me adjust them. I got to convince people to stop letting me adjust them, because we can do too much. So it goes both ways. And so that's why I play it by ear. There's some people, it's like, oh, you're really acute. I need to see you later this afternoon and again tomorrow morning. And I know that right off the bat. Other people are a little bit older, or they got something really bad. I set them, and they're thinking, am I coming tomorrow? No, you're going to come next week. I need to give that time to heal. And you're not going to heal quick. So I got to give that at least a week, and then we'll do it again, and maybe then we'll get a little more aggressive with it. So that's how I play them. But it's something that when I got in practice, I had no clue. Nobody ever told me when to have people come back. And then when I started figuring out the art of it, I realized why nobody ever told me, because there's no answer. It is what it is.
Yeah, for sure. And I think it's also hard too for us in school right now, because we're not allowed to take x-rays unless the person's nearly dead. So we just,
and then they can't stand up.
And so it's just kind of more of a kind of just go with the flow type of thing. Then if we had an x-ray that can at least know for sure which bone is the right bone to be on, and then also knowing everything a little bit more confidently, it would definitely make a difference. We have a question in the chat saying, how do you determine that it might be too much or not enough for someone?
Oh, you're going to hate this answer. Most of the time, by screwing it up.
Yeah.
You do one too many or not enough, and then you go, stupid. Now, this is really hard. In fact, it's funny. I was palpating somebody today, and it was mid-stroke. It was like C3, and I was really trying to palpate it. I was really focused, and he had somebody else with him. And as I'm palpating, she goes, how do you explain to students what you're feeling for? And I said, you want to know a secret? I can't. It's like the most frustrating thing. They're frustrated because they can't get it, and I'm frustrated because I can't tell it. Well, this is the same kind of thing that how do you know when it's too much or too little? Like, I'm trying really hard. I think a lot of times it's by how the adjustment felt, which sounds really weird. But I'm actually, as I'm making an adjustment, I'm feeling the condition of the disc. I'm feeling how the disc accepted the bone movement, and I'm just feeling a lot of that. And how that joint moves tells me, I often use the terms healthy disc or sick disc. A sick disc is probably going to need a little more time to heal because it's gone really far down that road. And by sick disc, I mean D4, D5, D6. A healthy disc, I often tell patients that a D1 disc is a super healthy disc. It's so healthy that it blew itself up and it's causing you trouble. But it's so close to being normal, it's only going to take a little bit of work and we'll have it back there. So you got a D1 disc, I'll adjust you tonight, I'll adjust you tomorrow morning, I'll adjust you tomorrow afternoon, you'll probably be better. And then once it's better, why would we mess with it? You go home, come back when you have a problem. So that's usually how I do it.
And you re-x-ray after that D1 disc gets solved? normally, or no?
Sometimes not. I've never been big on post X-rays. So this is the funny thing. For most of my career, I took hardly any post X-rays. Now that I do more teaching, I wish I would have taken a lot more post X-rays, especially on certain cases. And I think I'm going to start taking them now. I'm in the process of getting a new digital X-ray machine in here, so then I can cart them with me everywhere I go. So I'm mainly for those purposes. I want to get a digital X-ray machine, and I want to start shooting pre and post, and I want to start collecting a repository of pre and post films on people for teaching purposes. So I never did it that much. I wish I would have. But back in the day, film cost money, and people didn't want to pay for them. So it's me paying for them, and so just kind of go whatever. So I
2020 is coming out with a full spine digital X-ray at the end of this year.
Yeah, 2020 is who's doing mine here.
Oh, really? Yeah, I just talked to them recently, so it's pretty.
I shouldn't let you know the secret. I shouldn't say it if you're recording it. But how should I say this nicely? Life needs a software update.
Yeah.
Badly.
Yeah.
So Dan Lyons and I were talking about 2020 software, and he was like, basically in Dan Lyons terms, he goes, "You show me yours and I'll show you mine." So I said, all right. So I show him our software. It looks like a 1980s video game. And then he shows me his, and I was like, well, that's fancy. And I said, I want that. And he's like, for life? And I said, no, I want that in my office. So I started looking over it, and I was like, yeah, I want that. So I'm working on doing that.
You know, we saw this thing, CBC, cone beam CT scan they do for upper cervical. They're coming out with a full spine one within the next year.
That's what I want. We just went to an orthodontist, and they did.
Yeah.
I've known about cone beam for years because of dentistry, but I know that little tiny facial cone beams are hundreds of thousands of dollars for those machines.
I spoke to a rep because I was like, if you're going to do that, though, for chiropractic reasons, you should probably get in touch with some Gonstead docs to help. Because they have the cervical ones for the upper cervical docs and Nuka and all of them, and they have those people helping with the software. I was like, if you're doing full spine, I'd get in touch with Gonstead docs, because in order for the Gonstead docs to kind of want to hop on, they would also need some things for their analysis in the software. And the guy, yeah, that'd be awesome. But he said something around like $200,000 to $300,000 for the full spine.
That's actually a pretty good price for a cone beam. They did the cone beam on my daughter for orthodontic evaluation. And as they're going through the slides, I said, stop on that one, because it had her cervicals on it. So I could go through and evaluate all of her cervicals. I'm like, okay, she's good. They're going to the next one. So, yeah, they come out beautiful. As soon as I saw it, I was like, man, I want that for chiropractic, but I know it'd be expensive.
Yeah, that's what they said. It's going through FDA approval now. So they said within a year and a half or 2 years, it should be incredible.
Yeah.
But if there's any other, doesn't look like there's any other questions, but thank you so much for your time and coming on here after your long day.
You're welcome.
Thank you so much.
Yeah.
You're welcome. Yeah, it's fun.
Yeah, this was incredible. We really appreciate you meeting with us kind of last notice, trying to work with our times.
You're welcome. Yeah.